Hello, everyone. My name is Danielle Cunningham, and today's training we will be discussing understanding trauma. Now, our objectives for this training is to one, become knowledgeable of the leading causes of PTSD in veterans, two, to better intervene with veterans experiencing trauma, three, to increase knowledge of how to screen for PTSD when working with veterans and their families. Four, to understand screening for adverse childhood experiences and how they impact veterans with other PTSD experiences. And then five, to become familiar with 3 R's of trauma and how to successfully get to resolution or healing.
The most important thing to know is that there's a difference between trauma and stress. As I like to say to people, life sucks a good amount of the time. We all have jobs and situations that are really unpleasant. But the moment that situation is over, it's over. The problem with trauma is that when it's over, your body continues to relive it. My name is Bessel van der Kolk. I'm a psychiatrist, neuroscientist, and author of the book, The Body Keeps the Score. I got interested in trauma on my first day working at the Veterans Administration. 1978 was the year, and the Vietnam War was over by about 6 or 7 years. The very first day that I met Vietnam veterans, I was just blown away. These were guys who were my age, who were clearly smart and competent and athletic, and they clearly were just a shadow of their former self. Their bodies were clearly affected by trauma, and they had a very hard time connecting with new people after the war. Around that time, a group of us started to define what trauma is. And in the definition of PTSD, we write, these people have been exposed to an extraordinary event that's outside of normal human experience. In retrospect, that shows us how ignorant and narrow-minded we were, because it turned out that this is not an unusual experience at all. People usually think about the military when they talk about trauma, but at least 1 out of 8 kids in America witness physical violence between their parents. A larger number of kids get beaten very hard by their own caregivers. A very large number of people in general, but women in particular, have sexual experiences that were clearly unwanted and that left them confused and enraged. So, unlike what we first thought, trauma is actually extremely common. There's a lot of debate of what a trauma is to this day. But basically, trauma is something that happens to you that makes you so upset that it overwhelms you. There is nothing you can do to stave off the inevitable. You basically collapse in a state of confusion, maybe rage, because you are unable to function in the face of this particular threat. But the trauma is not the event that happens, the trauma is how you respond to it. One of the largest mitigating factors against getting traumatized is who is there for you at that particular time. When, as a kid, you get bitten by a dog, it's really very scary and very nasty. But if your parents pick you up and say, "Oh, I see that you're really in bad shape, let me help you," that dog bite doesn't become a big issue because the foundation of your safety has not been destroyed. We are profoundly interdependent people, And as long as our relationships are intact, by and large, we're pretty good with trauma. It's a subjective experience, and what may be traumatic for you may not be traumatic for me, depending on our personality and our prior experiences. The problem with trauma is that it starts off with something that happens to us, but that's not where it stops, because it changes your brain. Much of the imprint of trauma is in that very primitive survival part of your brain that I like to call the cockroach brain. There's a part of you that just picks up what's dangerous and what's safe. And when you're traumatized, that little part of your brain, which is usually very quiet, continues to just send messages. I'm in danger. I'm not safe. That event itself is over, but you continue to react to things as if you're in danger. We are talking about survival. We are talking about staying alive. And so some people go into fight flight, or on a more primitive level, people's brain shuts down and they collapse. You have these automatic responses that are not a product of your cognitive assessment, they're a product of your animal brain trying to stay alive in the face of something that that part of your brain interprets as a life threat. And the problem then becomes that you are not able to engage or to learn or to see other people's point of view or to coordinate your feelings with your thinking. Traumatized people have a tremendous problem experiencing pleasure and joy. But the core issue is our hormones and our physiological impulses that have to do with survival. Your body keeps mobilizing itself to fight. You have all kinds of immunological abnormalities, endocrine abnormalities, and that really devastates your physical health also. Oftentimes the physical problems are longer lasting than the mental problems. And the other thing that is terribly important is the impact of poverty, or the impact of racism, or the impact of unemployment. There's other societies that are much more trauma savvy than we are, where there is not an enormous amount of income inequality. Healthcare is universal, childcare is universal. A culture like that really looks at what are the antecedents for certain forms of pathology. So the big issue is a political issue. How do we rearrange our society to really know about trauma so that people who grow up under extreme adverse conditions can become full-fledged members of society? The sense of community and people being there for each other is a critical part of surviving.
Now, how do we define what trauma is? So we look at SAMHSA's definition of trauma. They define trauma as an individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. It also defines trauma as events and circumstances may include the actual or extreme threat of physical or physiological harm or the withholding of material or relational resources essential to healthy development. And they also define it as events and circumstances may occur as a single occurrence or repeatedly over time. So the American Psychiatric Association, APA, defines trauma as features that distinguish a traumatic event that include the following. So sudden or unexpected events, the shocking nature of such events, death or threat to life or bodily integrity, and or the subjective feeling of intense terror, horror, or helplessness, a result of anything that disrupts one's sense of safety, a normal response to an abnormal experience, or trauma disrupts their life path. So there are different types of trauma. So some types of trauma can be physical abuse, sexual abuse, or emotional abuse, unstable or unsafe environments, separations from a parent, maybe witnessing abuse or violence, neglect, serious illnesses, intrusive medical procedures, or natural or human-made disasters, or severe motor vehicle accidents or accidents. So within the last dedicated studies have shown that witnessing abuse or violence can be just as traumatic as experiencing the abuse or violence. So trauma is a subjective experience. So factors that may influence whether one experiences an event as traumatic. So there can be developmental levels, they can inherit or learn resiliency, or some external sources of support. Now, trauma is relative to the individual. So just because you experience traumas from something does not mean that someone else who was in that same event will experience trauma the way that you have experienced trauma, or even experience any trauma from that event at all. Now, an example here is that let's say two people can be in the same car accident. One person can walk away fine, they can sleep well, and they can get right back up the next day and go on with their life. Whereas it can take the other person a while to get back into a car, they definitely cannot sleep well, and they can be reminded daily of that traumatic event. So trauma is relative to the individual. Not everyone experiences trauma the same. So now we discuss the theories of child development. So child development theories focus on explaining how children change and grow over the course of childhood. Now, these developmental theories center on various aspects of growth, including social, emotional, and cognitive development. So we have four theories here. The first one is Jean Piaget. So he proposed an idea that children think differently than adults. So his theory provides a framework for understanding how children develop cognitive abilities. So if you look at his theory for children through the ages of 0 to 2, he feels these children have no object permanence. So this means that children between the age of 0 to 2 forget that items, objects, and people still exist even if they are not present. Whereas we look at Gordon Allport, his theory focuses on the different traits that make up personality. So although adult motives develop from infantile drives, they become independent on them. So his approach favored emphasis on the problems of adult personality rather than those infantile emotions and experiences. So if you look at his theory from ages 0 to 2, he feels children in that age are distinguishing the difference between pain and pleasure and now focusing on their physical self. Okay, now if you look at Kohlberg, his theory focuses on how children develop morality and moral reasoning. So the thinking process of when a child or one decides whether a behavior is right or wrong. So how one decides to respond to a moral dilemma, not what one decides or what one actually does. So his theory between the ages of 0 to 2 means that the child there can now distinguish whether to avoid punishment. Okay. And then lastly, if you look at Erik Erikson, he is a psychoanalytic theorist. He focuses on the social interaction and conflicts that arise during different stages of development. So his theory suggests encompassing the notion that we develop through an unfolding of our personality and predetermined stages, and that our environment and surrounding culture influences how we progress through these stages. So his initial stage, trust versus mistrust, parallels the mental illness recovery stage concerning the acceptance of mental illness and trusting the idea of recovery. So developmental tasks thwarted. So self-awareness and individualization. So normal development is that they develop a growing sense of self-advocacy, develop knowledge that they are other significant people besides their parents, Understanding that certain needs cannot be met within family and that certain events and experiences are not relevant to one's family. So, in the end, the individual would experience autonomy, personal power, and independence. So, certain developmental tasks may be missed or incomplete with abuse. So, all energy and focus on tasks of survival in a threatening environment. So there are 5 different types of impact to trauma that we are going to get into today. So the first one is affective, cognitive, behavioral, physical, and physiobiological. So when we talk about the effective impact, we talk about the fear or anxiety someone may get, depression, sadness, that hopelessness, grief, anger or irritability, denial, disbelief or shock, guilt, shame, or self blame. So, when a person has effective impact to trauma, they have difficulty believing in what has happened, feeling detached or confused about the trauma or event. So, feeling numb and detached and not wanting to connect with others or become withdrawal from those around you. So next we discuss the behavioral impact that trauma can have on someone. So this can look like avoidance, difficulty concentrating or staying focused, lacking in age-appropriate peer interactions, oppositional, aggressive, or destructive behaviors, sexualized behaviors, substance abuse, and self-injurious behaviors. Now, some responses to trauma can be normal, but then some responses here can be a little bit risky. So now discussing the cognitive impact that trauma can have. So these are distortions can occur in thoughts about themselves, the perpetrator, other people, social connections, and the world. And so it connects that following traumatic events, one will typically search for explanation when no rational explanation is found. Irrational beliefs, so the cause of the event may develop in order to gain a sense of control and predictability. So some examples here of cognitive impact is self-blame, so either blaming self for event itself or for not foreseeing or avoiding the event. May generalize the experience or betrayal by one person to mean no one is trustworthy. May see self as bad or lacking in some way, but justifies bad things happening to them, and may contribute to loss of faith in justice, God, and the future. So next is going to be the physical impact that trauma can have. So one person can have health problems, sleeping problems, eating problems, exaggerated startle response, muscle tension, fatigue, and problems regulating body pain. Now we discuss the physiobiological impact. So structures of the brain is dynamic, meaning the brain structure is interactive with brain functioning. The number of receptors in the brain for different receptors can be increased or decreased in response to many factors, including stress. Now, stress changes neurotransmitters and hormonal activity both in the brain and in other parts of the body, which then produces a physiological response such as increased heart rate, respirations, blood pressure, diversion of blood flow to skeletal muscles, and increased alertness. Childhood trauma and PTSD are associated with chronic changes in these physiology. Traumatized children may have higher resting pulse rates and blood pressures, so greater physical tension and hypervigilance. So continuing on the psychobiological impact, so it is important to note that every thing a person does, thinks, feels is associated with brain activity. Now, traumatic events have the potential to change or alter the brain's functioning. So when changes occur over a long period of time, it may contribute to maintenance of trauma symptoms. It may also contribute to structural changes in the brain. Now, in one study, children who had experienced interpersonal trauma, such as abuse or exposure to domestic violence, were found to have smaller intracranial value, so which is their brain size. So lower IQs, poorer grades, smaller corpus callosal, so which is the part of the brain that connects the right and the left hemisphere, and higher dissociation scores than children who had no trauma history.
Hi, I'm Mary Vicario, and it's been my joy to be a part of the Resilience Project for the last 5 years. Today, I get to talk to you about the hand brain. And I love it so much because it allows me to bring a model of the brain with me wherever I go. And I'm Italian, so I talk with my hands. So it's just a win-win all around for me. Feel free to do this with me. Between your wrist and your elbow is your spinal column and something really important called the vagus nerve. So the vagus nerve actually releases all of our feelings into every organ of our body. So literally, we feel our feelings in every organ of our body. And we don't get to decide when that happens. It just does it. So in fact, those feelings are the feelings that frequently drive our behavior, especially if it's something we do very quickly, or if it's something that gets us in trouble, or the things that bring the people we serve to us for help often come from those feelings they get in their body, not in those thoughts that we're so proud of, but in these feelings. The next part of our brain is the brain stem. It's the palm of our hand, and it's in charge of all the things we don't think about, all the things that keep our body going that we don't think about. For example, breathing, digestion, bladder and bowel control, which means that's not under your conscious control sometimes. Arousal, the type of arousal that hopefully has you awake right now while you're watching this video, and the type of arousal that makes you want to do things far more interesting than watch this video. It's also in charge of how much information enters your brain. And if you're on the autistic spectrum or you have trauma, it actually lets in extra information because it doesn't know what you're going to need to be safe. And that extra information can become very overwhelming very quickly. In fact, it makes all your senses stronger, so things are brighter and louder and they feel weird in your mouth and your clothes feel weird and get very stressful. And the other reason it can get very stressful is that all the information that enters our brain goes immediately to our fear center, which is the next part of our hand brain, which is our thumb. The fear center, also known as the limbic system, is in charge of 3 very important things that I like to remember through the word FAR. It's in charge of felt safety, attachment, and regulation. And it likes things to happen in that order, in fact. So when the information comes into the brain, it immediately goes to the fear center and decides safe or not safe. And if it's not safe, it keeps our thinking brain offline. But if it is safe, it lets the next part of our brain, our cortexes, our thinking brain, come online and give it a hug. But when it's not safe, it throws it offline. So when you're not feeling safe, it doesn't allow you to attach and work cooperatively with others. And when you can't attach and work cooperatively with others, it also doesn't allow you to regulate. And you can look like you're out of control. And it might look like a choice, but when your fear center's in charge, it's not a choice, because what it is thrown offline is your thinking brain, which wraps around the fear center and has all those wonderful thoughts and all those wonderful things we've practiced doing housed in it. But when the fear center gets afraid, throws it right offline. And the only part of our brain we have conscious control over is our thinking brain. So when our fear center throws it offline, all of those thoughts we're so proud of and that we've worked so hard on to help us control our behavior, they are out of our reach. And if the fear center can't tell, should I be afraid or not afraid, it always errs on the side of fear to keep you alive. So we want to find a way to get a message from the thinking brain to the fear center so they can work together when we're afraid. And we're going to look at how to do that. So our vagus nerve and our brainstem think in sensations and feelings. Our fear center, our limbic system, thinks in feelings and pictures. And our thinking brain thinks in pictures and words. So you may have guessed it, The passport from the fear center to the thinking brain are the pictures. When we can create a picture for what we want, we have a better chance of getting a message to that thinking brain, bringing it back online so it can hug our fear center.
Now, this is an example of a healthy brain. This is the instinctive part of the brain known as the primitive. This contains the brainstem, limbic region, and the amygdala. So this part of the brain is responsible for basic functioning, like breathing, blinking, heart beating, flinching, and digestion. But if you look at this picture, focus on how connected the temporal lobes are in this brain, okay? Whereas of now, this is a scan of a abused brain. Okay, so this image of an abused brain, this PET scan is from an orphan who was institutionalized since birth. So this shows the effects of extreme deprivation in infancy. So as you look at the temporal lobes there, which regulate emotions and receive input from senses, are nearly gone. So children with abused brains show signs of emotional and cognitive problems as they grow older. Now this image shows the difference of a 3-year-old with a normal brain, and it shows you the brain of a 3-year-old who has been extremely neglected. Now, just by visually looking at these two brains, you can already see a big difference just by visually looking at them. But one thing here is just you notice the different size in the brain. As you see, the normal brain is a much bigger size, where you see an extremely neglected brain of a 3-year-old is pretty much really smaller here in that image. So now discussing the end results of trauma. So clients with trauma histories will respond to their trauma history in the present. So they can discern that the content has changed. Clients with multiple traumas may blend those experiences together. Responses seem extreme, defensive, or self-protective. So these are their coping mechanisms. Maladaptive patterns is an attempt to master a difficult environment. So some additional ends results of trauma can also look like unstable relationships, the lack of trust in others, difficulty concentrating, lack of self-control, educational delays, lack of confidence in self, opposition to rules and directions, poor peer relationships, depression or mood swings, motivated by immediate reward, or the lack of unrealistic long-term goals. So now we discuss Maslow's hierarchy of needs. Okay, so Maslow's hierarchy of needs is a theory of motivation which states that 5 categories of human needs dictate an individual's behavior. So looking at the hierarchy, you start way at the bottom, which is those physiological needs. So things like air, water, food, shelter, sleep, clothing, and reproduction. Then the second step is the safety needs. So think of these as more as personal security, having a job, so that employment, having additional resources, health, and property. Then you move up to the love and belonging. So this is that friendship, the intimacy, those family relationships, sense of connection. Then you move up to the self-esteem. So this is the respect, self-esteem, your status, different recognitions, strength and freedom. And then lastly is the self-actualization. So this is the desire to become the most that one can be. Okay, so reaching your highest potential. So when we experience trauma, which most of us are at some level right now, we sink lower on the pyramid. So when we sink to the bottom, like when we were little, our focus narrows on basic needs and they become more tangible and more important. So data analysis have found that higher levels of stress were significantly related to elevated level 1, which is the physiological and survival needs, level 4, which is that self-esteem, and level 5, which is the self-actualization needs, but not elevated for level 2, which is that safety need, and level 3, which is that social relationship need. Now, one must satisfy their lower needs before addressing those needs that occur higher on the pyramid.
So now I get to talk with you about the 3 R's of successful trauma resolution. The first R is re-experiencing. The second R is releasing. And the third R is reorganizing. But before we get onto the path of the 3 R's of successful trauma resolution, we have to look at where we meet the people we serve, because they're not on the path yet. They're still caught in yet another R called reenactment. And the important part of that word is the act. It is the reenactment that causes the acting out behaviors, as they're often labeled, that bring people to our door. And what their brain literally is doing is reliving the trauma in the present moment without their thinking brain knowing it. And this reenactment is not a choice. It comes from the part of the brain we don't have conscious control over. And it feels like the trauma is happening all over again. It's a very lonely, frightening place to be. And when they're done, it may look like they have gotten some relief, but they have not. That person is caught in the trauma of the past and reliving it in the present moment. They don't feel safe. They are just as frightened now as they were when the trauma happened. And it's not a choice. It's not a relief. And it's something we actually can help them move beyond. Where the 3 R's of trauma resolution comes in is that the first one, re-experiencing, can happen depending on how we react to someone's reenactment. If we reflect the fear that we see and we honor that they had the courage to show us that fear, and we connect them with the fact that they're safe and in the here and now right now, we literally allow that person to re-experience that trauma, not from a place of being alone, but from a place of connection. So when you get to re-experience that trauma with a safe other, whether it's through drawing or writing, the person no longer feels alone in that moment. And it literally takes them off their hamster wheel of reenactment. You have helped heal their brain. So the second R is when we honor what they've done to survive, and that allows their brain to release their trauma from the central nervous system and put it in the memory center of the brain where it belongs. We are helping their brain release their trauma, and we're also giving them dignity for the survival they have already done that has gone unrecognized. And then the third R is my favorite, because once you've released it, you are aware that the trauma has happened, but it is no longer the central organizing feature of your life. Then all the energy your brain was taking up, keeping you in the past and looking out for the future and not allowing you to live in your present moment, is freed up for you to decide what.
So keys to providing trauma-informed care. So need to presume that our clients have experienced trauma. So instead of what is wrong with you, maybe asking what has happened to you. So the need for an understanding of the vulnerabilities or triggers of survivors to provide supportive care and to avoid re-traumatization. Survivors need to be respected, informed, connected, and hopeful regarding their own recovery. So understand that there is a correlation between trauma and symptoms of trauma, such as substance abuse, eating disorders, depression, and anxiety. So continuing with some more keys to providing trauma-informed care. So set up a calm and nurturing environment. You want your client to feel comfortable. Be conscious of the person's demeanor. So if someone is beginning to move from a calm, continuous state to a state of emergency, if so, you want to model caring and compassion and adjust the environment if possible. Also, be aware of language being used. So an example here is using a diagnosis when referring to an individual. So now we discuss veterans with trauma. So the number of veterans with PTSD varies by service era. So the data above are from a large study of veterans across the world. So when you serve in the military, you may be exposed to different traumatic events than civilians. The war you served in may also affect your risk because of the types of trauma that were common. War zone deployment, training accidents, and military sexual trauma may lead to PTSD. So this study here, like I mentioned, is from a large study of veterans across the world where we look at PTSD in the past year. So looking at the service area for Operations Iraqi Freedom. You see that is out of 15 out of 100 people. So 45% of people in the past year has experienced PTSD. And if you look at the second column there, PTSD at some point in their life, that 29 out of 100, so 29% of people who have served in OIF services experience PTSD at some point in their life. So continuing with veterans with trauma. So PTSD is slightly more common among veterans than civilians. So at some point in their life, 7 out of every 100 veterans will have PTSD. So in the general population, 6 out of every 100 adults will have PTSD in their lifetime. So PTSD is also more common among female veterans, so 13% versus male veterans, which is a 6%, will experience PTSD. So we are learning more about transgender veterans and those who do not identify as male or female or non-binary.
You know, 70 and 71. Then when I came home, you know, I knew it wasn't the same because before I went over there, I was happy-go-lucky, laughing and everything like that. When I came home, even to this day, I don't smile. I didn't talk about Vietnam, and I thought that I would spare people because, you know, Vietnam was not a nice place. When I came home, I know that I've been, started drinking more, and also that I couldn't really hold on to a job. I couldn't have a successful relationship with a person. I would maybe be with them for about a year or something like that and break up, and my jobs, I couldn't have anyone like bossing me around. When I did go to restaurants, I had to have my back up against the wall looking, so I'll be able to look at everything. I just keep thinking somebody is after me. And I figured there was something wrong. I had a short temper. I kept yelling for, you know, no good reason. And so I went to the VA, and what they did is they said, well, do you have PTSD? And I said, you know, I don't even know what PTSD is, so I don't know. And they get you familiar with what PTSD really is and how it's going to affect you and why it affects you. And it was pretty nice to know that there's a reason for what I was doing. So I would definitely recommend any veteran go and try to get help. It is very much better knowing the reasons why you're like you are, and also to be able to work things out.
So now we're going to discuss adverse childhood experiences, so ACE. Now you guys should have received one handout that has the ACE questionnaire. So if you want to have that handy, we're going to go into adverse childhood experiences. So first, how do we define ACEs? So ACEs are potentially traumatic events that occur in childhood. ACEs can include violence, abuse, and growing up in a family with mental health or substance use problems. So toxic stress from ACEs can change brain development and affect how the body responds to stress.
A child's experiences early in life are important building blocks for the developing brain. Genes, nature, are like the blueprint. They provide the basic framework for brain development. However, genes do not design the brain completely. Environmental influences, nurture, fine-tune how the brain works by shaping which brain connections get used. Connections that are used more grow stronger and more permanent, whereas ones that do not get much use fade away. Together, genes and the environment build the foundation for all future development. Safe, stable, and nurturing relationships early in life lead to healthy development. But children's brains capture other experiences as well. Stressful events. However, not all stress is bad. Positive stress involves normal childhood experiences, like starting daycare or meeting a new person for the first time. This stress is essential for healthy development because it helps children develop coping skills and confidence. But when stress is frequent, chronic, and uncontrolled, it is toxic to children, especially when they do not have a caregiver to provide support or buffer the stress. Adverse childhood experiences, ACEs, such as abuse, neglect, exposure to intimate partner violence, parental depression or addiction, and poverty, are toxic stressors which could lead to lifelong changes in learning and behavior. ACEs early in development can impact social, emotional, and cognitive functioning, increased risk-taking behavior such as drinking and substance use, and increased risk of disease, disability, and social problems later in life. The question is, how do adverse childhood experiences impact a lifelong development? One of the most important systems in our body is our stress system. It's activated when we experience stress. We become alert, our heart rate increases, and so do our stress hormone levels, cortisol and adrenaline. Our body is ready to react, what is known as fight or flight. A short period of time after the stress is over, or if a child receives support from a caregiver, the stress response turns off and the body returns to a normal state. Adverse childhood experiences create stress responses that stay active, and without the support of a caregiver, the system has difficulty shutting off completely. This constant and prolonged activation can affect immune system functioning and increase the chances of sickness, infection, and disease. Prolonged activation of stress hormones is also toxic to the brain. Certain areas of the brain are more vulnerable to toxic stress, including the executive center or the brain's control center, an area important for solving complex problems, attention, reasoning, impulsivity, inhibition, and learning. A second area is the emotional center, the brain's alarm system, which is involved in processing and interpreting emotions and the ability to control impulses. The third area is the memory and learning center, the brain's filing cabinet, which plays a major role in learning and the formation and retrieval of memories. Science shows that adverse childhood experiences impact all of these brain centers. Behaviorally, what we begin to see is emotional distress, poor emotion regulation, greater impulsivity, learning difficulties, and physical and mental health problems. More recently, science has begun to look at how ACEs cause changes in gene expression through a process called epigenetics, which helps us understand how nature and nurture interact. Epigenetics causes changes in the way genes work without changing the DNA code itself. This occurs through chemical changes influencing how the code is used. In other words, genes are like the hardware in a computer. They determine the boundaries of what is possible. However, we need an operating system to tell the hardware what to do. Epigenetics is like the operating system directing the function of a gene's DNA hardware. The genes we are born with are the genes that we have for life, but experiences like nutrition, exercise, smoking, stressors, and relationships all affect our biology. Adverse childhood experiences are associated with epigenetic changes related to stress, brain development, cognition, and systems associated with mental and physical health. Changes that happen early in brain development are more likely to be enduring and are possibly passed on to future generations as well. The good news is that positive, supportive relationships at any stage in life can make a difference. However, supporting families and children early on will help prevent many of these negative outcomes. One of the key ingredients for healthy development is having warm, loving, and actively engaged caregivers. This involves promoting serve and return interactions, where caregivers actively and warmly engage with the child, making eye contact, responding to sounds, words, gestures, emotional needs, and sharing experiences like reading and play. Providing programs that support caregivers to strengthen these abilities are the blocks that build healthy foundations for life.
Now, this is the Adverse Childhood Experience ACE questionnaire that you should have received at the beginning of this training. Now, this widely used and validated tool is used by trained providers to measure the impact of childhood abuse and neglect upon well-being. Now, if you do complete this with the client, now if the ACE score is between 1 to 3 without the ACE associated health conditions, then this client is at intermediate risk for toxic stress. If the ACE score is between 1 to 3 and the patient has at least one ACE associated condition, or if the ACE score is 4 or higher, then the client is at high risk for toxic stress. So as you do this with your client, you want to just make note of their scores and differentiating if they are at risk for toxic stress or if they are at high risk for toxic stress. So continuing on with adverse child experiences, so data shows that there is a striking association between trauma and illness. So this study provides estimates of odds ratios for having conditions in adulthood if a person has experienced ACEs in the childhood. So ACEs in childhood are strongly correlated with adult disease. So people who have experienced 4 or more category of ACEs have 2 times the rate of lung and liver disease, 3 times the rate of depression, approximately 3 times the rate of alcoholism, 11 times the rate of intravenous drug use, and 14 times the rate of attempted suicide. Now, there are 3 types of adverse childhood experiences. They include abuse, neglect, and household dysfunction. Now, with abuse, it can look like physical abuse, emotional abuse, and sexual abuse. Neglect can look like physical abuse and emotional abuse. And then household dysfunction can include mental illness, maybe an incarcerated relative, seeing their mother being treated violently, substance abuse, or divorce. Now, there are potentially traumatic events that occur in childhood, so maybe the ages from 0 until 17 years old. So when collecting trauma history, it is not necessary to take a detailed past trauma history to create an environment that is receptive and responsive to their trauma. So this can be very overwhelming for those who don't have healthy coping mechanisms developed and have active substance abuse. So instead, look for markers of trauma to help guide treatment offered. So what are markers of trauma? These are health conditions that are highly correlated with recent and past trauma. So they include heart, lung, and liver disease, obesity and diabetes, substance abuse and overdose, and mental health as in depression, PTSD, and anxiety. So some possible risk outcomes can be the behavior, so the lack of physical activity, they may be engaged in smoking, alcoholism, drug use, or they have starting to miss work. And then the physical and mental outcome is severe obesity, maybe that depression, suicide attempts, STDs, heart disease, cancer, stroke. So all of these physical and mental health outcomes. So some approaches here is to use trauma lens. So assume that a client's trauma may have contributed to current medical conditions. Using a trauma-informed approach and offering serves to heal from past trauma along with traditional medical therapies may lead to better outcomes and experiences of care. Numerous behaviors correlated with having experienced trauma or having PTSD that are often attributed to personality disorders, and these too can be considered markers and include being reactive, easily triggered, easily offended or angered, withdrawn, or disassociated. So these are some other factors to consider. So it is important to acknowledge that many providers and staff themselves have histories of trauma. So working with patients with such severe illnesses and such significant histories of trauma can cause vicarious. So conscious awareness of our own trauma helps us maintain a professional and therapeutic stance towards our patients with trauma. So we can use guidelines for inquiring about trauma and past trauma, which is known to be less triggering or dangerous for our patients and less overwhelming for providers. So nothing in particular that you need to do when a person reveals their past history of trauma other than hear it. Acknowledge that you heard it and thank the client for trusting you with this information. With the revelation of significant past trauma, the most important thing to do is offer statements of empathy and support and acknowledge that it is really helpful that they had the courage to even tell you their history of trauma in the first place. So, guidelines for inquiring about trauma. So, 1, assume history of trauma without asking. 2, screen for the impacts of past trauma instead of the trauma itself. 3, inquire about trauma using open-ended questions and use a structured tool to explore past trauma experiences. So here we give you some additional links to resources here, and then just some additional resources there. And now we have time for QA and discussion. So are there any questions that you have? If you want to open the floor for discussion here.